critical thinking junctures, and definitely leaning into the adult 2 content and its collective. So the first class is going to be triage. Okay? Yes, triage. Now triage, we're going to go into all of this. It's a very, very important piece in being able to focus on our resources. So, of course, again, we talked about it the other day about parenting. This is exactly, what the ED is the apathy is most famous for, right? The guy's got a knife in his head and we're more concerned about the spelling of juggling, right? So, this is about 12, 14 years ago. Do you think it's gotten better? Crisis in the emergency room. Has it gotten better? Why do you say no? Because that's what you're expecting you're supposed to say? Is that, I'm kind of like leaning towards it, like this, so he'll keep talking and leave us alone, we'll say no? Why is it worse? Let's go with that. COVID put us way over the top, but the conditions were right for the collapse of the system for COVID. Any system right now that's going to require a lot of people to be in it, because of the way the emergency rooms are set up, are going to collapse. Look, has there ever been a patient at a university emergency department? Anyone? Well, if they were still there. That's why they couldn't raise their hand. Because if you go in with anything other than a major trauma or significant like a chest pain where you're having an MRI, it's just an overwhelmed system. It's not that they don't want you back there. The beds are that precious. And some of the reason is emergency rooms lose money. Now people you see that there's a new market out there, and you see it all the time in the news, the offload of these urgent care clinics, right? Has anyone ever gone to an urgent care clinic? Raise your hand. Okay, what were you billed? A lot, right? So those make money. And patients go in there thinking, it's just gonna be like an emergency room visit. But you can walk out literally with a cold pack and be $1,000, $1,500 in the hole. That's before monitoring, that's before x-rays or anything else. So the gap in the industry is this very expensive concierge opportunity, and it's those urgent care. And it is an offload. But patients that really need to be in the emergency room, patients, that don't have the ability, because that's beyond the Affordable Health Care Act. Did you have to pay a good portion of that? See, so if you do not have a means, you don't have access. So the basic population, for the most part, is still stuck in this overwhelmed system. So here's some objectives. This is a 1 hour lecture, 15 minutes or so. So how many questions am I going to ask from it? 3 to 4. 3 to 4. So do you think I'm going to worry about the minutiae and demographics? Okay, good. Let's just go ahead though and look at what happens when triage goes wrong. Nurses get overrun by the system, and if you respond with apathy, and you're like, I'm just too overloaded, you make it about you instead of your patient, doesn't make you a bad person, it's just where your focus is can make you a dangerous provider. And this is the first time, actually, this is a true case. This was in Illinois. 49-year-old woman died of a heart attack while waiting in Waukegan emergency room. She died while waiting in the emergency room. And her daughter was with her. You can look this case up, and I can flip a couple others at you too. So anyway, she was having chest pain. They triaged her, told her to take a seat. First of all, with women's health at this point, what do you know about women's health and atypical chest presentation with chest pain? Right? Very different, right? Because most of the data is based on what? White men, 50 and older. It doesn't include anything else as far as gender or ethnicity differences or even lifestyle differences. So the data that we have and we work off of, when you hear, this is when it's going to happen, you're going to have pain generating to the jaw and down the arm. Yeah, that can be true, but it also can be deferred pain. It can be very different. So anyway, she didn't have the classic symptoms. And then the daughter, who was an adult, also went to get the nurse, and the nurse asked her to take her seat. We will get to her when we can get to her. And that happens all the time. I ran the emergency department. Actually, I was responsible for everything we did wrong, I should say, at BAMC. And those are comments I would hear all the time from the folks that work for me. And they were overrun. And they really meant that they could only get to them when they get to them. But you don't say that, and it doesn't mean you don't at least reassess the patient when alerted. So the woman then died of a massive MI that was already started at time of triage and presentation. She died in the waiting room. Now, here's the deal on this with triage. The nurses actually, for the first time ever, you'll cover this in leadership management next semester, right before we cut the cord and send you guys on your merry way to get sued on your own. Anyway, so the piece of this was they did reassess. She went in with chest pain, and this time they looked at it as a felony. Because normally it's like negligence or something like that. This was gross negligence that reached the threshold of a felony. And if you lose a case to a felony, you're going to prison. Okay, it's no longer a fine and I'm getting sued, this is crazy, right? And financial is one thing, but this woman initially was at risk. It's never been done before, so it didn't have quite the threshold of intent. So they had to pull back, but the public was basically just short of an old Frankenstein movie with pitchforks and torches, because remember, nurses are the number one respected profession. You guys are in the number one respected profession. Not paid, but respected. And with that said, the public felt betrayed collectively. The public felt betrayed collectively, and it reached the threshold. So the secret for this is, how do you handle these stressful times, still take care of these patients that don't seem like they're dying? You have to follow an algorithm. You have to follow an unbiased approach, just like looking at a 3-lead, right? If you guys looked at enough 3-leads, you have a certain way you look at it every time now, right? If you just look at it, it's got a P wave, it must be okay. No, you got a bunch of other things to look at systematically. So, to avoid horrendous cases like this from happening, I'm going to provide with you something that's going to provide structure. Because look, the beds are full, limited access to health care. Emergency rooms themselves are losing money other than these fancy standalones. Because of that, they're closing, so emergency rooms are actually closing down. So they're just leaving the weight of it on the county facilities. So when you want to go, who wants to go into emergency nursing? Raise your hand. And hands are dropping. Okay, so with that said, there's a lot of work to do and there's a lot of liability with it. And there's hot beds of care that the patients stack on top of each other. So 114 million visits are made to hospitals. So that comes out to what? That most ERs are above capacity. And I'll tell you, in San Antonio, overwhelmingly, they are. You only have 2 trauma centers in town. You used to have 3. Wilford Hall is the airport. You had BAMC was Army, and you had University. Well, Wilford closed, and then we combined practices. So BAMC is just a mega center, and so is University. We've all expanded our bed space, but does not cover the masses, because San Antonio is a growing city. We are not capable. So how do we continue to do this? Now look at some of the other demographics, 65 and older. So we have a lot of boomers plus out there, right, that are overwhelming the system. And then utilizations, even if you look at culturally, there's different utilization rates. Sometimes it's about where you're at, socioeconomic, and when you look at rates, what is the Latino population of San Antonio ratio? It's like 65, 70%. So you gotta remember, these are national sways, right? So different numbers, different places. These are sways on a national level. In town here, it's very different. So we have to be able to do things, and I think I've set the case that as we're going to talk triage. And what does triage mean? Who speaks French? And should I say with the accent? Triage. Hey, triage. To sort, simply to sort. So this is what we need. So you have triage. I'll tell you what we normally had, and it was ineffective, and lawyers shredded the triage process that we use collectively. It was a 3-level triage system. And it was emergent, which is the obvious one, resuscitation in progress. Urgent with the crushing chest pain and dysrhythmia, or obviously, persons in obvious distress of some sort. And then non-urgent. Those are the 3 categories. In order to work around it, what we would do is, you'd be in triage, you're like, okay, this person's sick, but they're not like gonna die in the next hour. But I'll make them the non-urgent, and I'll put a little plus sign. That way my buddies in the back know, this is, if I'm going to pick one as non-urgent, this is the next one to go. Because remember, it's not on the order of arrival. It's not on the order of arrival. So you have to be able to still do it. But when you start to see patients that deteriorate, and the ones that you think are non-urgent that continue to fail and get really sick while waiting, those are the ones when they look at this chart, well, you've made him non-urgent plus, so it's a non-urgent patient. But I wanted him to go next if he was non-urgent, but he wasn't, he died. So at that point, the triage, you have nothing to stand on. There's no clinical judgment provided, just a category. So we need to probably have something more. So it's to be able to provide care for each individual patient and assessment. Now, according to the rules, the Board of Nursing rules collectively, so if you as a nurse, licensed nurse, who's going to be a bachelor's prepared licensed nurse too? Raise your hand. All right. And you have no hope? What's going on? Nothing? So with that said, you're going to have all the responsibility is upon you, even though the physician's in the back room. I always call it the doors and deniability. Until the physician puts hands on that patient, their existence is based off of your observation and annotation and assessment is what stands between them and fate. So you can triage and you put down what you put down, that little scrubbly note, that little go ahead, is it urgent, non-urgent, is the only thing, because the physician is not on the line with you. The institution is that hires you and your license. So when you assess a patient, so you can see why I'm making the case is often young nurses make everything emergent, right? Because no one wants to cook off in a jail cell somewhere. So, and then you have the older nurses, right, my group, that are apathetic. Nothing's sick enough to be here. So then you have the extreme, that nothing deserves to be in my emergency room, so everyone gets non-urgent for the most part. If you are not hemorrhaging, and if you are, it better be hitting the ceiling, or I'm not paying attention. So you have those extremes. So resources get utilized in the most bizarre way too. So you have to review charting heavily, because practices deviate, even though all have the same license. So what you have to do, you have to have a nurse that is trained. So I'll tell you a remedy as we were coming up with things, is I set up an entire group of just triage. I budgeted for just nurses to be hired as triage only. Because otherwise, you have the experienced nurses and there's big cases going on in the back. All they want to do is superstar, right? They want to run back in the trauma room and save the day, while they're sitting out here with Johnny Snotnose. Yeah, I've had a call for a week and a half and I'm just miserable. And they're like, and you hear, get another crowd, go crack the chest! You know, they hear all that going on. And they're like, I don't want to be out here. So, all I had was triage nurses that did triage. And it really helped a lot, because that was their focus, that was what they did. And then I set it up where they did triage, that if someone else wanted to make a change on their triage status, it could only be a higher license. So another nurse that was just exhausted in the back couldn't take her triage and change it, because they would like to do that too. Got to help settle down the numbers. So only a physician could change it, and if they did, they had to write down a rationale. That means they had to see the patient in order to change the triage. That's fine. So I created those rules, and our litigation rates did go down in the interim when we're putting these processes together. So you can see that currently 96% of US use EDs. Now, with that said, we have systems in place now. Who's actually worked as a tech in an emergency room somewhere? Okay, can you tell me the triage process they use? It's okay. I think you're wearing your jacket backwards too. Okay, all right. So anyway, so I can understand our level of confusion. Okay, so what's the big deal here then? It helps us with our acuity. We made the case. So now, because of all the litigation, you can see where there's even felonies. There was another one, I think I might have it at the end of the slide deck. The lady died in the Los Angeles emergency room, another big county hospital, and she was so sick and so much abdominal pain, her family was so freaked out because the nurses were so apathetic that they called an ambulance to get her there and take her to another hospital. The ambulance refused transport because she was already in the hospital. And she died right on the floor in the emergency room. How bad does it gotta get? And this is long before COVID numbers and everything else, or even flu time or anything. This is just overrun departments and apathy. So what we have is, along with the Emergency Nurse Association, I'm a member, and of the state and local. And then you have the American College of Emergency Physicians. So we all work together. Is a dysfunctional family at Thanksgiving. That's what every emergency room looks like. With that said, we do work together on what quantifies and qualifies our patients for triage and resources. So we came up with the new triage system that's a 5-tier, and we're going to work with that, and that's what you're going to be tested on. Okay, so it's a 5-level system. It's called the Emergency Severity Index. Now, if you want to look at practice scenarios, I'm going to give you a couple, but if you want to look at practice scenarios, you go to AHQ, and you can go ahead and look it up, the ESI, and it'll take you onto the website. It's free resources for nurses and physicians, and they will run, this is where I generate all this information from our approved sites. Almost all the facilities use this now. So the nice thing is it used to be Canadian, there was different types of triage system in play. Now, collectively in the United States, a 5-tier system of any emergency room of magnitude uses this system. So you're welcome. So you go by 5-tier, acuity and expected resources needed. Because remember, when a patient goes into a bed, that's one thing. But what do you need to do for that patient while they're in the bed? You have to do suturing, you have to do x-rays, you have to do an IV, you have, medications. Is this patient going to be admitted? They can go from, really, just stick out your tongue, yeah, it looks pretty brushy, you've been on antibiotics, we're going to go ahead and give you something and send you home, to, oh my goodness, you're going upstairs in like 10 minutes and you may have surgery on the way. That's a very different patient. So this triage system does help account for the resources and anticipated outcome of that patient. So it's got great reliability and validity. So it's been studied. We've worked it through for a good 20 years. So the data is very strong. This is one of the better systems. And there's not constantly suggestions, even because of data, building on top of data, refinements all the time. So again, AHRQ, you guys need to know that site, especially going into leadership and management. It's stacked with resources. Free resources that hospitals can implement processes. It's a great sidebar to reinforce evidence and practice as you build your practice. So here it is. Here's your 5 tiers. Obviously immediate, that's resuscitation in progress. And then it needs to be seen. The next one needs to be seen within less than 15 minutes, and that's the emergent. Crushing chest pain, diaphoresis type of thing, right, where the patient isn't able to ambulate. That's important. And then the next one is urgent. That one needs to be seen within the hour. That's the patient maybe with, has a history of renal calculi, severe pain, diaphoretic, but it is located in your focus assessment, lets you understand this patient's in a lot of pain, needs to be seen, but will probably not die in 60 minutes or less. And then the next two are really about resources. Semi-urgent and urgent. 1 to 2 hours, that patient's pretty sick, needs to be seen, irretractable nausea, vomiting. Do you have any pregnant ladies in the room? So the vomiting, you're waking up, sometimes they get irretractable, you guys did your OB, where they just keep vomiting and vomiting. They have the electrolyte imbalances and everything else. That patient would be semi-urgent, most likely, but needs IV, probably needs additional fluid support and assessment, and also maybe an OB room, just to go ahead and assess fetal status as well. And then you have the non-urgent. That's still the big bucket of crap, right? Just a big bucket. That's the collective of cracked fingernails from pressure, can be old sprains. It can be the patients that come in from 3 days ago, have really bad neck pain because they're in a motor vehicle accident, and don't have the bias of saying, because this is the problem. A patient's probably non-urgent, because you're thinking, they just want the insurance money, so they're here 3 days later. Well, 50-50. Also, there's going to be patients that actually have pain because they actually have an undiagnosed fracture, because they never were seen at the scene or whatever else. I can, for instance, I can tell you when I broke my shoulder blade when I crashed my motorcycle, all I was concentrated on was how sore my shoulder was. I had no idea I had a massive meniscal tear. It was until I saw the gas tank had a big divot in it, and I'm like, look, my knee was purple. It was a couple days later, and even then, I was still very concentrated on the shoulder blade because that hurt a lot. So you're going to have patients that are going to come in with nondescript injuries, and they may have significant additional injuries. So please make sure this non-urgent group we're going to talk about gets the most concentrated, unbiased, formula, rhythm-based assessment possible. Because these are the ones where you get biased, like you roll your eyes, they don't belong here type of thing. These are the patients. Remember, you only need one lawsuit to ruin your life. And most likely, that patient's going to be in that bucket of non-urgent. Because you miscategorized them because they didn't present, they had bias. You know what I mean? So along with that, you're really busy. And so that non-urgent, make sure when we talk about this is the patient gets most attention on the front side. And if you do it right, I may not have to ever touch them again. You know what I mean? But this one I want to warn you about. So it's a 5-tiered system. So here's some of the applications. All right, so the goal for all patients to be assessed within 5 to 10 minutes, not the full piece. That's where you put eyes on them and you see them. Now, this is a really good one we use in PALS and stuff like that, or in TNCC, different trauma courses. Everybody make a little triangle with their hand. Do this. Do this. Does everyone do this, please? And look at me through the triangle. Look at me through the triangle. Heart for all you. Okay. So here's the deal. That is your first glance. That will give you about 80-90% of what you need to know about that patient. If you're looking at them before they know you're looking at them, because theatrics will come out. You know, patients will come in, they're like this, and also you know you're looking, and they're like, oh, you know, they're going to add on to it, because I mean, everyone's fighting for, it's an audition. Everybody wants to get to the stage first, right? Especially the non-urgents. So you got to see them before they see you, and that first glimpse is going to give you 80-90% of what you need to know about that patient, just on presentations. The rest of it's going to be hands-on the patient and vital signs. And then a little bit of history. And again, the problem with history in the emergency room, you don't always get the true story in the front side. Patients will come in with knee pain, and they may very well have knee pain, but really what it is, it could be an STD they're worried about. It could be anything. It could be a pregnancy, but she's there with her mom or dad, and she doesn't want to really talk about it right now, so she's going to stick to the lower leg pain until you get quietly away from someone. And once she's like, I can't have an X-ray. Why? I can't have an X-ray, right? Okay, and that's when the real story starts to come out. So you have to be a really good listener. You've got to stay away from bias and assumptions, or you will die on the vine before your patient. So here's what happens. So here's the foundations of it, right? High index of suspicion. Everyone is dying until they prove otherwise. If you start on the other side, and Sandra Kolbos was he worked with us in Germany in an American emergency room. He was Soviet-trained Hungarian physician, and he worked the other side. You have to prove you're dying. So I'm going to get an EKG of the patient with chest pain. He'd be like, no! Then I have to read it, right? He wanted you to prove. He'd rather give them an Atlanta before an EKG, you know, until they prove they're dying. So Western medicine side of the house, collectively, on an international basis, patients are all dying until they prove otherwise. Now quickly, just by them presenting, they can immediately drop that rung of suspicion. But you have to start off, everything's dangerous. Everything's a bomb, okay? So with that, you have to know your A and P, anatomy and physiology. You have to know your pathology. And now this other piece in the middle of all this, and this is the part we've kind of been hinging on from the time we talked in clinical to now. Interpersonal communication skills. It can't be the ankle. It has to be a patient that has ankle pain generated from something, not just the ankle, okay? That's very dehumanizing to say they're just, or it's that. It's a person that's obviously either scared. I mean, there's still, I mean, you're a nurse. There's things that may be, at the end of the day, just coaching and teaching. But you have to go ahead and build this in. You have to have that public relations skill set. But you put yourself, remember, you know, this is a fact. But just remember this. Are you more likely to get sued if they don't like you or like you? If they don't like you, automatically the suspicion is extremely high, and your risk of a lawsuit immediately climbs up. So just think of it just from how you feed your family or yourself. Maybe I just need to be cool. And then, of course, the medical legal aspects. When you misbehave because you are hired by the institution, you put your facility at risk as well for a huge lawsuit just because they hired you. And you're acting out, inappropriately. Now, let's go back to the focus on the patient instead of you. So it's that cross-the-room assessment I talked about, going through that triangle, just taking a look at it, and the rest of it's eye, ears, nose, fingers, and hands. You have to touch and feel. So if there's a life-threatening situation, you have to be able to learn how to look through that crowd and be able to pick up those that really need your assessment before anyone else. Sometimes 5, 6 people are going to present in a cluster, and one of them's a time bomb. 3 or 4 really are going to be leaving with cold packs, but you don't know that yet. So you have to have the ability to sort that, and this is what you have to do. So triage, right? Airway, and I always say little c, and we'll talk about that in trauma follow-on. Little c, because you gotta always think about C-spine when you're doing airway assessments on patients. And then breathing, circulation, disability. What's AVPU? What does that stand for? It's a much quicker version of the Glasgow Coma Scale. No points attached to it. It's just, are you awake? Can you respond to voice? Do you respond only to pain, or are you unresponsive? Okay? Of course, you will get a Glasgow Coma Scale, but on a presentation, this is all you're doing. And awake and oriented times 3. And then, for pain, you find what is used. What's going on? What's the level of pain? It's not even about treatment. It's really what the pain level is. Right? Has anyone had a chance to see Dope Sick yet? Anyone? Raise your hand. What do you think? It's got it. You get a chance during the winter break. Not now. God, no. Not now. But Dope Sick on Hulu. It honestly, for me, once you guys see it, we can crosstalk, because that was ground zero for how it changed my practice, and it's all related to pain management. Pretty insidious. But anyway, so we got to know about age. Why do we got to worry about age on a triage patient? Why? Why age? I can take it. Right, there's certain risk factors just automatically associated with advanced age, right? And then why male versus female? Again, we just talked about it, atypical presentations. You have to take that into account. And then past medical history, is that important? Right, even though you're doing a focus, you still got to have to kind of get an idea what's going on with that patient really quickly. And then, of course, what's their medication? All right, still, it's not as bad as it was in the 80s and 90s, but polypharmacy is still an issue out there. Patients are going to come in with bag O meds, and you got to sort through them, because that may very well be what part of the malady is. So you have to go through it, and it takes time. And you got to be careful, especially if you're handling patients' narcotics and everything else, because they will immediately try to accuse you of taking their narcs. And at least be clean, okay? Because that is, especially if they're drug seeking, you got to remember, you got to always protect yourself too. They're drug seeking patients. They're not bad people, but they have an addiction. And they may be there for drugs. So as soon as you start handling their drugs, you are at risk. And then, of course, allergies, huge, right? We all know that. So now you got to do that interview. And we want to do it quickly. See, it's 5 to 10 minutes. I mean, look how long it's taken me just to tell you about it. You got to be able to get in there. You have to be very directed. The nice thing is, a lot of places have what called T-sheets. They're very directed questionnaires that already have been scrubbed. It kind of gives you a way you're going to go through it. Plus, once you're in the position, you kind of have to learn what your practice looks like, how you want to practice. And part of that interview technique is part of your practice. So it may be different than me. Certainly will be different than mine. And if you sit with me and you do mine, well, that's great, but that's not you. Your practice is your licensure. That is your skill set. You take bits and pieces of other people's practice through observation, and also then nurture and grow your own practice. And this is one of them. The interview process is, you guys did health assessment. Remember when that was? What was way back when? Right? You all if you actually watch the videos, everyone really had the same objective, but each one of you looked uniquely, horribly different. Did I say horrible? Yeah. You guys look so amateur, it was hilarious. But look where you're at now. I mean, you cringe where you were, where you are now, right? It's called growth, man. You know, you got to start somewhere, and that's where you started. Health assessment's your first tool in the bag. But have you guys built on it, or have you actually deteriorated? And you know what? Some of you can honestly say you are actually better in health assessment than you are now. Stop that problem. Do not let that. Do not go into your last semester with us over the holiday. Tune it up, because that tool set is imperative to wherever you're about to land in a few months. Okay? That's the first line of defense and basic patient care. So then we have to look at the patient's complaint. And again, understand if it's fishy, trust your gut, because that complaint may very well change. If it's that kind of a nuanced type of thing. I mean, obviously, I have a nail in my hand, and it's going through their palm, their hand coming out the other side. Chances of it being a concern about an STD is pretty low. But it could happen. But the story still can change. But let's just say that's pretty objective. But when people come in with nondescript abdominal pain and everything else, it could be a lot of different things. So leave it open. Past medical history, and also kind of making sure you know where you're at with the patient. Make sure they feel safe with you so they can tell you their story. So if they don't feel safe with you, they will clamp down. And you're not doing anyone any good then. And then, of course, this is where all that information is there, is where you have to make your license assessment as a BSN-RN, what their status is going to be. And that's part of the permanent record. I don't have time to do it anymore, and I don't have the stomach to do it anymore, but I used to review cases when I was 9 months faculty here during the summer. I would take cases outside of San Antonio, emergency room cases that, for lawsuits, and I would review cases. And it's all about the triage. It's all about what we did after the triage, the nursing component and the hospital. Physician groups settle out, they don't even play. The hospital groups, because they're so large, the hospital's so big, that there's so much more money attached to a settlement from the physician that the hospital's on the line with you. So they have to stand with you. So those cases are most interesting, but they hinge right here on the triage severity rating and what we did for that patient after. So do know, I don't want you to be afraid of the emergency department, because it's really some of the coolest work you may ever do. But know that you have to have your what's the term? Poop in line. Okay, because if you are online, you really got to want it, and you better be good at it. Because if you just want to be exciting, but you don't want to put the work in, well, woe to your patients and you. So here it is, nursing fundamentals and triage, type of illness, what's going on, and then after that, the mechanism of injury. So you'll see it the rest of the time, even in the trauma lecture, MOI, okay, mechanism of injury. Because obviously, let's just talk. If I get hit by a Corvette, where's my most likely point of contact? Lower leg, right? If I get hit by a F-150, everything, right? Probably chest and head. So with that said, mechanism of injury is someone who's on a ladder. What else do you need to know if you're on a ladder and they fell off? How high it was, very good. So these are all good, you guys are tracking, so this is very important. So how did it happen and when did it happen? And sometimes the patient may be unconscious. You got to get it from whoever saw what happened. And then, of course, you have to touch the patient. Sorry to tell you. And you guys grew up with gloves, right? You put gloves on for everything. You understand it's important, but sometimes you got to make a choice. It's all part of the art of nursing. Sometimes an ungloved hand is a better approach to a patient, because a gloved hand is a barrier, basically saying I'm dirty, right? I'm potentially dirty. And you have to make that decision. If you're bloody and really sweaty, yeah, you're dirty. That's all there's to it. But if it's just a little old lady coming from the nursing home and put gloves on and a mask and coming at them like, Johnny Robot, it's creating a barrier that may not need to be there. And that's your choice. You do what you got to do. Mind you, I started off, without gloves, and we didn't do any of that. So gloves are a barrier, more for me, purposeful barrier than probably for you. But this is something I want to point out as you build your practice. And then think, will they die on me? You got to have that process. You got to think that through. And I can give you a case or two, and I will as we move through, where the patient was pretty benign looking and did not make it to they died in the stall, the bathroom. So, well, you guys already had acute abdomen, right? You did the aortic, dissecting aorta, and that was the case. It was a good nurse, good provider. She saw the patient, and he was, of course, crotchety old veteran, so I'm fine, my wife made me come in, blah, blah, blah. I need to go to the bathroom. So when he was in the bathroom, he had to push, right, because he had that sense, but it was really deferred pain. It was his aorta that was erupting open. So he hemorrhaged to death internally on the toilet in the bathroom. So, once again, I'm going to ask you, think, will they die on me? Does that have a little more meaning now? Okay, I mean, and she was concerned. She did go back and talk to the charge nurse who was going to place, saying, I really think this guy needs to get moved in. I'm not sure why. So she had the right gestalt, she had the right sense, but it all happened very quickly. It really wasn't like he was gone for an hour. It all happened within 10 minutes or less. So will he die on me? And then, will the problem get worse? That ties right into that story as well, right? Along with our lady that was allowed to die in the emergency room and the one I talked about in LA. The thing is, when you're done triaging, it's not enough. One of my triage nurses with a $20 million lawsuit, was simply, she was 32 years old, came in with shortness of breath at 93 on pulse ox, little dusky, little diaphoretic, struggling, and ordered chest x-ray 2B, not taken yet. And then he had a bunch of other patients he had to see. And the husband came up and said, hey, I need to look at my wife again. And he made the mistake of saying, hey, I got to see these other patients that haven't been seen yet. I'll get right to her when I can. But he never got back to her. And it was another nurse that came in then for triage because we finally got to. It was around 11 o'clock. Immediately saw her slipping away in her chair. 32 years old, shortness of breath. Well, she was now horribly diaphoretic, barely able to sit upright. Got her in a wheelchair. And the energy it took to get her in the wheelchair and then got her to the gurney to put her onto the bed in the emergency room, that took so much energy from her, she went to full respiratory arrest right then and there. She had to get trached, she had to be put on a ventilator. What she had was a streptococcus pneumonia. And the strep pneumonia ran through her like wildfire. It wasn't a normal type of pneumonia. The strep pneumonia, within 2 hours, went from a non-urgent patient to I'm going to die patient. And when she was saved, she was rescued. She, had to have a trach, got damage, had to go to rehabilitation afterwards. Life was fine for her about a year and a half later. And it was a huge $20 million lawsuit. And that was some of the synergy that I used to actually use to saying, hey, we can't let this happen again. That was kind of the synergy I used. We'll talk about that Lean Six Sigma when we talk leadership and management. But will that problem get worse? So you remember, triage and done is not the way. It's hypervigilance throughout. If you're the only person that saw that patient, remember, no one else is responsible except you. Share responsibility immediately. Share the mess. So PQRST, you guys should know that, right? Is that still on the acute abdomen? Right? Just know this. It's a nice little acronym to keep you honest. Make sure you do it the same way every time. Make sure you assess Johnny toenail, fungal toenail, the same with the guy that fell off the ladder and hit his head and had a 20-second period of unconsciousness. Gets the same initial triage, okay? Same way every time, all the time. So remember, 5 explicitly defined categories that we have. This will be on the test. And I will give you information. If I ask you a question, I will provide you what you need from the category, ESI category, in order to be able to move forward. So it allows for rapid sorting. And it's very good. The ESI will give you the level if you follow the simple rules coming up. Here it is. This is everything right here. This is your entire algorithm. It's pretty easy. Is the patient dying? Yes or no? Shouldn't wait? Yes or no? And how many resources? Remember, that's your non-urgent. Is it going to require an x-ray, just an x-ray, or require just an IV? And I'll come up with a list of what qualifies as a resource. And then, of course, you got to look at vital signs. Remember, vital signs change all of the time. Just one set of vital signs does not equal assessment and care. So here we go. Is the patient dying? Does the patient need immediate life interventions? Remember, I'm slicing this out, and I'm going to give you scenarios now for each one of these options. So hey, is the patient dying? Does the patient require immediate life-saving intervention? So maybe a patient's coming in, they're allergic to fish, inadvertently they had shrimp salad, and there you can see the face is puffing out. Is that the end of it? Go ahead, they're obviously breathing okay right now. And is that patient going to get worse? And if they do get worse, what is it going to require? Possibly intubation. Now, will that happen? We don't know, but do you want it to happen in the emergency room department? I mean, outside of the care in the back? No, right? We're all in violent agreement on that? Okay, so those are the types of things I'm making this. So is it obstructed? Partially obstructed, especially with children. Epiglottitis. How does the child with epiglottitis sit? Right, good. So if you make them lean back because it's just easier to put them on a bed, what happens? It goes from partially obstructed to obstructed. Ta-da! You about killed the kid. Great job. So these are the things you have to know, be aware of, and also constantly running in your head as you're sorting through. What does apneic mean? All right, well, what does it mean though? So if they're not breathing, you got to consider, is it an obstruction? Is it a lack of an ability to breathe? You know, all those things have to come into play. Did they have fractured ribs? Right, remember? Did they have fractured ribs and it's been there for, maybe 2-3 hours? Now they have a pulmonary contusion. They can become apneic because they can't breathe because it's all filled with fluid and they can't move their chest wall, right? All these things have to come into consideration. Have they been intubated pre-hospital for whatever reason? Now once you get to that level, is this patient dying? Yeah, they are, right? And then severe respiratory distress. Any age group. Different reasons, different drivers, any age group. And right now, COVID, right? Has anyone had COVID? Right? So you understand, respiratory distress. So patients a lot of times have been sent home with a pulse oximetry, thinking that they were okay, and then a day later had to come in and get intubated because they pulse ox, right? They went home and stared at the pulse ox, and eventually, 2 days, a day later, they had to come in and get intubated. Even though they were properly cared for, they almost died at home. And this is just the world, that's just reality, and this is the world we have to live in, but that's what you do in the emergency department. Okay, the patient dying, obviously they're pulseless, they're hemodynamically all over the place, and low blood pressures. IV medications have to be done for, offering stability. You all did simulation now downstairs, right? You did the acute cases with the physician and everything, yes? Have you all done it? Is it good? Did you have to get medications out and stuff? Okay, so you understand what we're talking about. So does the patient have an acute mental status change? That's huge. Can be drugs, can be oxygen level, right? Can be blood pressure, can be a ton of different things. But that has to be accounted for, not just yes, but also what's causing it, what do we need to do next. And then hypovolemia and heroin, right? Heroin's out there, so Phenoxylone, Narcan, have you guys all had the training on that? Distribution. The other Dr. Cleveland runs it for the entire region. She works with mommies that are recovering, and also distribute to all the police and the fire departments. They distribute Narcan. If you need Narcan, you have friends that are at risk, let us know. We can get you Narcan and training if you need it. But that's very, very important. So did that patient require Narcan on arrival? Important to know. Because if they are awake, they're going to be miserable when we wake them out of their stone. And they're also going to drift back into it. So it's only a window. So you have to know that information. Is it going to get worse again? Now, obviously, subarachnoid, any bleeds in the brain are going to be a problem. And that also immediately takes you to ABPU. And ABPU again stands for? Please stop. You're saying that's what you're saying. Okay. So here's some of the things that you're going to see then. For triage ESI category 1, things that we probably think should go right to the back. No stop. No triage in the triage room. Let's just get them back and finish it up there. It's going to be a gunshot wound to the abdomen, chest pain, pale, diaphoretic. You're going to have dizziness, recent loss of consciousness, chest palpitations. So anything that has a heart rate of less than 40, right? Bradycardia. Who has a heart rate of 40 or less in this room? Some of you probably do. I used to be able to drop mine below 40 to stay conscious, and I hover in the 50s, but 40 is not good for me anymore. But most of the time, is it clinically? Patients can be bradycardic, right? But if they're bradycardic, are they symptomatic? You just don't go with a number. You have to tie something to it. And then severe stroke. Who's at Baptist or Methodist? Or even at university at this point, right? Do you have stroke scales over there, right? Boom, right? It's a whole different triage level, right? and they have a quick thing to do for assessments and how they're going to manage that patient goes into a whole different category. And that's really good because stroke protocols are still a little bit lagging in San Antonio, but we're getting much, much better than we were. Do they have the bathroom? Oh, good. So if you feel there's a really long wait, go ahead and read ahead. You're going, oh, you know what? Just kind of practice, have your mouth droop a little bit, and get right to the back. Get your cold back. So they're warning, they're trying to teach the patients in the bathroom, or is it for the nurse's bathroom? Oh, really? Well, that's smart. I mean, everyone needs to know. You're right. I'm just kidding around, but we need to know it. Now, how do you assign the triage category? Can they wait or not? Can they wait or not? Because remember, until anyone else sees the patient, this is all your call. And then the pieces could help you with your license, because you're not practicing medicine. You are a licensed nurse. You don't make diagnoses, but you have to work with the data. As a nurse, a licensed nurse, you still got to work with the data. And the rest of it, policy and procedure. And ESI is actually part of that policy and procedure. The physician can take this because of their licensure. They can technically throw anything away that's an algorithm because of their practice supersedes these types of guidance. Now, most of them don't have the stones to do that, thank God, but they can because of their licensure. But you, as nurses, have this as a policy and procedure along with your license equals practice, okay? I'm going to make sure you're not practicing medicine. You are practicing nursing within the realm of your license along with policy and procedure. So, is it a high-risk situation? You have to go through this. Now, again, once it's high risk, this is where you do a rapid set. You're not going to get a full set of vital signs. This is where you're going to start going to the auto pumps and everything else if the patient's obviously that bad. Is it unsafe for a patient to wait? What would be something that where the patient's not bleeding or actively dying that you'd be concerned about? Can they wait? Remember your psych simulation? What was that patient all about? Suicidal ideation, right? So that patient comes in, at least they came in, right? But now they're at risk, right? And they're going to require at least one person to watch them the entire time. Think about the desperation a lot of times your patients coming in with suicidal ideation. They need to be sequestered, they need to be quiet, they need to have dignity, not to escalate, but yet to be safe and watch them and also keep them attended to. Now, if you have a really, really busy emergency room, that's a big ask, guys. That's a big ask, because a trauma can take 15 people at some time. And you have to be very, very careful with these patients, especially as it's new onset. Very high risk for everybody. And now, signs and symptoms of a condition that's treatment is time sensitive. Again, we talked the allergic response can keep getting worse. A burn, inhalation burn, and everything else. A lot of times burn patients more than walk in on their own. And when you see them 2 hours later, you cannot believe that this patient walked in sometimes. So will it get worse? And then again, is it a potential life-threatening or an organ at risk? Right? Is an eye? I mean, an eye is still an organ. Does someone have a nucleated eye? They got punched, maybe their eye's kind of hanging out a little bit. You know, it's a big deal, right? So that person, even though it's just an eye, they got another one, but we've got to get that taken care of. So is the patient confused, lethargic, disoriented? This can be anything. It can be, again, blood pressure levels, this can be oxygen levels, this can be drug-induced, it can be dementia, it can be delusion, blah, blah, blah. So we have to rule out in some cases, right? We talked about this, pulmonary embolism. Again, I can tell you a patient had a pulmonary embolism. Initially we're treating as a suicidal ideation because it was her drug, her medications, her bottle was empty. So the ambulance made the assumption and the bias that obviously because she was acting kind of crazy and her bottle was empty and it was the anniversary, known anniversary of her mother's death. And her mother, when her mother died, affected her greatly. So they picked her up, they knew this patient, they assumed that she did an overdose because she was acting crazy. And it turned out really, because she lost consciousness in the ambulance, got to us completely unresponsive and without respiration. She had a massive PE is what she really had, but they had a bias. Instead of doing the assessment, they ran off of the physical piece, in history, but didn't do the full assessment. And they delayed time, and she did die. It was such a massive, it was a saddle, one of those massive PEs that she had. So again, you have to be methodical, and you can't let the obvious be considered obvious anymore. Everything has to have a weight to it. You have to be, you have to be McGruff. You know, remember McGruff? Right, you gotta be the investigator, the detective. Is that too far back? So, and then of course the needle stick. If you get a needle stick, I will lose my mind when I would hear that I had a nurse that has a needle stick not getting brought back. I don't care what the category, whatever's going on, that we leave one of our own back terrified with a potential contaminated needle stick. That patient, come hell or high water, is coming back to get treated because you're one of our own, you're on the front line. I insist, and so does this protocol, get that nurse back. Get that nurse back. First of all, just for emotional support, especially if it's a known hepatitis or an HIV patient, get that patient back, which is you. So you see that? It's in blue. Needle sticks get back too. So, is the patient in severe pain and distress? Remember, those of you that watch Dope Sick, this changes everything. Practice is about to change again. Pain right now, currently still what the patient says it is. So then when I started practice, pain obviously had to have some sort of physiological response to it. And slightly elevated heart rate, at least some protection, some blood pressure change, breathing. You had to have some level of some pain distress. That was the way I started practicing. By the 90s, watch Dope Sick, you will see that suddenly pain is whatever the patient says it is. Whatever they say it is. If they are sitting there, they're watching, YouTube and laughing their butt off, and they said this is the worst pain of their life, but it's a 10, it's a 10 right now. But it wasn't like that. Right now it's still a 10. So the first thing Joint Commission is going to ask, they're going to grab the most baby nurse they can find in the emergency department, which will be one of you, and they're going to ask you, because they do what they call tracers. They don't want to talk to me, the guys running the place, because I have all the corporate answers, right? They're going to take you. What's your name? What is it? Emily. So your patient right here came in 20 minutes ago with complaint of gout and a lot of pain in their leg. First question they're going to ask, what was the first thing you did for pain? Which is not to be dismissed, okay? This thing's going to, the pendulum's always going to swing. But the first thing they're going to ask you is they're going to start to walk you through the tracer of the patient's arrival, the triage, and what you're doing for the patient right now. Joint Commission doesn't want to talk to the docs or the nurses running the department. They're going to talk to you. And they're going to ask you that first thing. What's that patient's level of pain? If you do not know their scale of pain, if you do not know what the triage category was, you are automatically, in Joint Commission's eyes, negligent, and so is the whole facility. If you don't have a CPR card on you, or have proof of, having a current CPR card, the facility will get shut down by Joint Commission right there. It's all part of the work of life. So here it is. Scale of 1 to 10. Scale of 1 to 10. Now you're going to have just the opposite. Some people are very stoic and will lie, but they will be sweating, they'll be gritting their teeth, and they'll say, I got maybe 2, maybe 2, maybe. And then you can have the other one, oh God, it's all of them. So it's a personal experience. At the same time, never be dismissive. Please don't dismiss someone's distress, regardless of their smile or over theatrical appearance. It's still their experience, not yours. And you respond in kind. Don't dismiss. Don't tell them, oh, it doesn't hurt that bad. Make sure you still have a good, healthy response for them, and it's therapeutic, not dismissive, or you're just irritated with them. Okay, now that's easier said than done. Patients will try your last nerve, but you're being paid, remember that, not to act on it, okay? And then the Wong Baker, right? You guys use this in peds mostly. Also patients that don't speak English. We use this very successfully. And we make sure that it's communicated. If you have a patient that does not speak English, let's just, that especially, it's easy enough to have interpretation for Spanish and everything else, but you're going to get offshoot, patients, and if you just give them this and they don't really respond to it, that is not a triage of pain. You do know that, right? You have to make sure every patient has a right. You don't have anyone there that speaks Vietnamese. You have to at least highlight this person speaks exclusively Vietnamese, and some sort of, before you can finish your triage, that patient has to have full communication available, or you have just now done an incomplete triage on a patient. And the hospital will have policies set up of who you call or when you call. Sometimes it's a telephone, sometimes someone comes in. but you have to make sure you highlight this person, that you are communicating with them, not just guesstimating. Okay, that's all part of your triage as well. Now, ESI level 2. Patients with burns of both arms, dislocated shoulder pain. Why is the shoulder dislocation so concerning? They have to be seen in less than an hour.
It could be a heart attack.
Actually, within 15 minutes. What?
Could it be a heart attack?
Do what?
Heart attack?
You can also have injuries, but in particular, shoulders, if they're not relocated, can actually kill off the nerve plexus. And if that's, especially if it's a posterior dislocation versus an anterior dislocation, all those things have to get that shoulder back in socket quickly, or the damage can be permanent even if reduced. So a patient with the burns, and then of course psychiatric patients, talking about that. Now they may not be suicidal, they just may be psychotic. And those patients will disrupt the room. So you have to figure out a way, because has anyone ever seen a full psychotic patient in the emergency room? And they are, if they enter in the round, the more response, because people then start to laugh, some get weirded out. Either way, that's the attention sometimes of that when they're in full crisis, that sort of thing allows them to even escalate more. So you have to really, with some tact, get that person isolated out of the area, and understand they are going to say horrible things to you. And some of them actually may even be your hidden secrets. And they may hit nerves, but you have to walk and talk through it, okay? They're going to say obscene things to you. But yet you got to get that person out of the room. First of all, it's still a HIPAA violation, because technically their crisis is there, and everyone's watching. And the longer you let them play it out in that group, you're really violating their rights. Patient rights. So it's a hard. Now this one's hard, but this patient's still very dangerous, because it can be dangerous to you and others. So this is where security and police come into play, along with psychiatric emergency team and nursing. But nurse, you have to start all this in the triage area. So how many different resources are needed, right? This is what we're talking about. So decision, how many resources? So part of the standard of care, this is what the hospital can charge for. So you can see what's a resource and not a resource. Now I won't test you directly on that, and if it is, I will give you enough information. But resources are labs, EEGs, not a resource though. History and physical. Actually, I'm okay with most of this except phone call to the PCP. You got to call a primary care provider from the emergency room and waiting on a call to come back. That's a resource, because that nurse may be back and forth with the call service 6-7 times sometimes before you complete that communication. But they didn't ask me. So anyway, so look at what's a resource and not a resource. Some of this stuff's just expected part of the state. And the additional pieces are, especially a suture. Now, a suture, even gluing a wound on a 4-year-old. Has anyone ever seen The Incredible Hulk? A 4-year-old, even in a papoose board with 6-7 nurses and docs holding him down, can destroy a room. Just trying to get that wound approximated, even with glue, much less suture, that child becomes superhuman. And they are strong. They're amazingly strong. You will probably lose your teeth. Be careful. But that is a resource because of that particular, right? That child needs to be held safely. The child you have to anticipate. So all that's going to take bodies and material. It's probably a non-urgent, kids fall down all the time and have small splits on their forehead and lips. But this is going to be a resource, so make sure you account for that. So what's a level 3? Fractured ankle, abdominal pain, migraines. Why are migraines a level 3? A couple things. So what? Right? It could be a stroke. Even though they have history of migraine, doesn't mean they're immune to stroking. Right? And also there's just pain. First of all, these patients are debilitated with pain often, right? And sometimes there's a nice formula that follows, and maybe a 3-drug and oxygen formula, but these patients need to get back and get treated. They're not going to get better, especially in a noisy emergency room with bright lights and everything else, okay? So here's some other for level 4. So now we're in the non-urgent zone. Healthy 19-year-old with sore throat and fever. It could be mono, right? Could be COVID, for God's sake. Now you got to add that on to it. It could be numerous things, or it could just be a cold. Healthy 29-year-old with a UTI denies any discharge. Doesn't mean she doesn't. Doesn't mean she doesn't. But right now she's telling you, you got to work with what she told you, because you're going to defer the pelvic examination in the triage room. okay? You're not doing a pelvic, okay, I promise you. Now, healthy 43-year-old with a stubbed toe, I think I broke it. Actually, Aaron Rodgers is 38 years old today, and he's got a really bad toe, doesn't he? So anyway, I thought I'd mention that. So Aaron would be a level 4 doing an emergency room right now. And then also, now what do we do with a broken toe sometimes? What do we really do with it? See, Aaron didn't need surgery on his foot either, by the way. Aren't we all excited knowing that he's got a bye week, relax. The point is, a lot of times he'll his buddy tape it, right? The entire treatment can simply be a big piece of tape that's going to tape the healthy toe next to it, maybe it's braced. Or orthopedics may choose to do K-wiring on that, and then they do an outpatient. They may actually go upstairs, depending on the level. But this patient's a level 4. And then a 12-year-old with a minor thumb laceration. Will there be resources involved? Will 12-year-olds freak out you got to sell their thumb? Oh God, yeah, and they're even stronger than 4-year-olds, which is hard to believe if you try to hold a 4-year-old. This 12-year-old is going to be like, oh my God, like Krypton. I need Krypton to slow Superman down because they are going to go crazy. 12-year-olds are in between worlds. They're kind of mature, but they regress immediately, and they are strong. So it is a level 4 because of resources. Level 5, here it is. These are the patients. Now, mind you, as nurses, when you're in the emergency rooms, do not get angry with these patients because these also assure that you have jobs. Because even the BAMC trauma, really, we only have like 8 traumas a day. Is that enough to employ 120 nurses? No. These patients keep you in the paycheck right here. So do not deny these poison ivy rashy patients. These are the easy money patients, okay? See them, treat them well, because these are really the ones that keep you employed. Absolutely. Be glad you have these. These are easy, they're fillers, they're quick assessments. You're usually pretty pleasant. You just got to ask them to stop scratching, until they get calamine, and send them home. And also you have a patient there, car accident 2 days ago, wants to be checked, but nothing really hurts. And then 46-year-old with a cold. Now again, with the cold, what does that mean today, right? It's very different, right? This could be COVID, right? So this patient probably has to be masked and isolated, and you have to wait on COVID, at least rapid response, rapid results, I mean. All right, so one additional thing is the danger zone. By the way, when does Top Gun 2 come out? But anyway, so there's things, especially with 3 months old in pediatrics, fevers on a little baby. Is that concerning no matter what? Huge. Time to antibiotic is something you have to track. It's that child can deteriorate so quickly. And also elderly patients with sepsis. You guys went through sepsis. I can tell you, I've had a healthy 78-year-old guy walk in Bermuda shorts, sitting down, and I just feel horrible. And I will literally go to my office and come out sometimes like 50 minutes later just to make my rounds on the patients. And that patient is on a Vigiligo, they're intubated, they're going upstairs, because they just completely turned that quickly and were septic. They completely succumbed to the sepsis. And they're literally going to go upstairs to the ICU, and that quick. So will that patient get worse on me? Yeah. Do you know that? No. So what do? You have to be conservative and let that be, share the responsibility. You can always, and don't take it personal if someone downgrades the patient in the back with a rationale. It doesn't mean you did the wrong thing. You were working with what you had. It's okay for a patient to be downgraded, I want to point that out. But for you to downgrade yourself and then for a patient to be upgraded, you're really going to be under some scrutiny. Because that's immediately, it's an error. It's a near miss. So these are what we're looking at. So these are things we're looking. So triage category. This is the pediatric. Just take a look at this, please. Just know this. I'm not going to read this. You don't know all this. But look at the ages. Consider the ages. So here's a little clue. This is adult 2, right? So do you think I'm going to be asking pediatric questions? Okay. Does that alleviate you of licensure issues? No. Okay, so I want you to take a look at this. Just know this, that children with fevers and respiratory issues are huge. They're all under protocol and algorithm. Pediatric societies and physicians and everyone follows, especially on these children. We're very regimented on these types of criteria for good reason. And again, this is everything we just showed you all in one sheet. These aren't in the bathrooms in the emergency room. But they are in every triage room, and a lot of times we put them all up on the walls and everything else. We do the same thing, right? The propaganda is that everyone gets reminded that when you patient, for the physicians in the back, I put this up because I want them always to know the policy and procedure, the American College of Emergency Physicians and the Emergency Nurse Association agreed and researched this data. So when they start to poo-poo, they have to realize that this is the policy and procedure of a licensed nurse providing the best care they can in assessment of their patients and moving them to the back. It's very important. So again, secondary assessment, that's going to get the patient, now let's take you from triage of the patient, taking care of the patient in the back, you're going to do a secondary assessment at that point, head-to-toe examination and everything else, but it's still going to be the same, primarily focused. Unless it's a trauma patient, like you were stating about, if there's enough to dislocate the shoulder, there may be other injuries, and this is where that part comes into play. And then diagnoses. Now, again, you may use a nursing diagnosis, but here, this is where the physician or advanced practice nurse or PA will come up with a diagnosis for you to work with. Once a diagnosis is rendered, of course, you'll know the protocol that follows that type of a diagnosis, and you'll know how to anticipate the level of care which you're going to be providing. And then planning. First of all, there's two patients in the emergency room. Two kinds of patients. What are they? It's only two kinds of patients that come to the emergency room. What? Well, you're basically right. It's too sick to go home, not sick enough to stay, right? So immediately when that patient in the back hits the bed, your planning process for landing is either working discharge or admission. You are working towards one or the other. I mean, you may require stabilization, of course, but that patient has a trajectory. That is not their holding bed if you don't want it to be. Now, university, unfortunately, becomes a holding bed, but guess what? An ICU nurse will come downstairs then and get assigned. You get your hands on that patient as soon as possible, okay? Whole gig on ERs, you don't have to get to know anybody that well. So here's a quick case study, and then we'll take a quick break, and then we'll knock out trauma. So, we're going to do this triage thing. We're going to go ahead and work through levels 1 through 5 using ESI, which stands for yeah, that's right. Good guys. Good. Talk about feeling. Okay. So we're going to do this. We're going to run it. I'm going to have a reader. Who wants to read for me this paragraph? Who would like to be a reader? You know, I haven't heard you since like semester 1, really. So go ahead. I want modulation. I don't want just monotone. All right. Okay. Here we go. So what we're going to use is the algorithm, and here's your case.
A 70-year-old male arrives by ambulance from the nursing home. The nursing home reports a non-productive cough since he choked on his lunch today. His baseline mental status is unchanged, although he is normally confused. Skin is warm and moist, vital signs, temperature is 100.2, heart rate is 94, respiratory rate is 20, blood pressure is 135/80, SpO2 on room air at 94.
Excellent. Round of applause. Talk amongst yourselves. What's his ESI like?
Yes, sir. I think level 2.
So here it is. Does he meet level 1?
What about his mental status? He's not responsive, just confused. So maybe he doesn't meet
What
level
about
2
mental
feature.
status?
What about severe distress?
What about severe
High
distress
risk.
or high
Is this a high risk
risk?
situation? Would you give
It's
this
a high
patient
risk
bed?
situation.
This is actually an ESI level 3.
That's close.
So what's his category? Talk amongst yourselves.
Where'd you get that? I have a PDF.
Is that 3? Let's see. We can look here too.
Where did you get that? Where did you get that PowerPoint?
Online.
I know. Oh, there.
Prior to arrival are BP 102/60, heart rate is 86, Respirations are 28, and SpO2 is 96.
Thank you, round of applause.
Sir, hide this from me.
All right, can you hear me? Good, okay. Let's get excited. All right, we're gonna do trauma resuscitation, which really is gonna be completely, this trauma resuscitation is the nurse's focus on being part of the trauma team, which also is gonna, again, take everything you've learned and compile what your responsibilities are. We're gonna do it through the ABCDs, okay? We're gonna systematically walk through your role in an acute resuscitation.
What is this?
See that fracture?
Yeah.
And actually, that's what it looks like. It's called an ORIF.
Which one of
Whose
these?
arm that is?
What? Because it says.
Yes! Yes, I was an engaged teacher. I had a nursing program in the Army.
It's him.
And this guy was an ex-cop from Hawaii, was going into the Army nursing program, and he wanted to arm wrestle me. So I arm wrestled the guy before this case, and I beat him. He looked like Bull from Night Court, if anyone's old enough to remember Night Court. So, big guy. So I just got done beating the guy, and this guy was like, hey, I just want to give it a shot. And I said, fine. It's called physical challenges. It's military, right? It's what we do. Not anymore. But anyway, so the guy got me on the table, and we're up there, everyone's around. I've got him almost all the way down. This guy wasn't all that bad.
I don't think so.
I'm almost all the way down here. And I'm like bouncing him, and I just can't quite touch his knuckle to the ground. And also he like screams, like, ah, right? I was like, my arm just shatters, right? So, don't try this at home. That's a trauma. I did, and it was wicked bad. It was bad. It hurt. It hurt really bad. It sounded bad, and people were all screaming and stuff, so I was the officer in charge of the room, so I still had to say, I lost my right to, my effing arm, right? I couldn't do that, so I had to like pull it up. All right, what you just saw and what I felt and we all heard is likely, it's an open spiral fracture in the humerus. I'll take your seats. Sergeant Brown, if you could get Sergeant Jackson's truck and drive me to the emergency room before I crap myself, I'd appreciate it, you know? And that's a true story. Anyway, so that's a trauma. And I did. I had a very, very good visceral response. The sweat started coming down on me, and it was pretty bad. Now, the guy that put it together for me is Tim McHenry. We were together in Houston. That's why I had this up there. McHenry was the orthopedic trauma surgeon I taught with in Houston at Ben Taub. And I taught trauma for the Department of Defense in Houston, and we kind of covered that the other day, those of you that were there. So McHenry put that in there. But since my arm fracture, I immediately, again, when you know too much, I immediately thought, I was 40 years old. So the warranty for the record comes off at 40. For the record, know that. Anyway, I thought for sure I had a bone tumor. I thought for sure I had cancer. I did. I thought pretty much so. I was very reserved by the time I got to the ER holding my arm. I thought, really? This is the least of my worries, honestly. So my buddy McHenry came down, and he's an ortho, and I said, hey man, he did the CT and everything. I said, do I have a tumor? And he goes, well, your arm doesn't, but I haven't scanned your head yet, And I was like, because everyone's like, and the question was, how big was the guy that broke my arm? He really wasn't. He was just viscerally guy. He was just all, Anyway, it was horrible. So Tim McHenry, so our trauma team that we had in Houston, a lot of this content is based off of our time and working with the American College of Surgeons and the Emergency Nurse Association and somewhat the emergency physicians. But this is a trauma lecture specifically, so nurses and surgery are going to be working together. And I was just talking with a group of students here. Trauma is a surgical cure. Until we get to the OR, nurses have to participate and anticipate quickly in the resuscitation process, knowing your role and knowing what has to come next, okay? It's a very big deal. So it's just the facts. It's way too slow. Anyway, trauma is the leading cause of death for individuals younger than 45 years of age. And it's the 4th overall cause of death in the USA. Now that might, I think because of our statistics, that might be slightly off now. A trimodal distribution of death. Now we talked about cases, immediate, early, and late. Those are your tri-mode of death. So the immediate Is your case immediate? So sometimes patients just die right there on the scene. That patient is an immediate cause of death. That's the one in Texas. They don't even have to do a full rhythm on a patient. They go and assess the patient, and they can just say, the paramedics are able to declare, along with, there's Medcom, we'll talk about that in the next slide or two, call it in and just say patient's deceased on scene. That is not our work in the trauma room. Early, in the trauma room for the emergency department, early is our case. That 30% of those patients is our work. They're the ones that come to the emergency department in some form of resuscitation in progress or needing care. Late, who's going to be critical care nurse? Critical care, you guys now, and ladies, and everyone that's going to be critical care, and the LFAT. Is that an LFAT? I thought. Okay, sorry, something shiny, I can help myself. Anyway, those in critical care are going to take care of the late patients. These patients that die are the ones that after resuscitation, everything's done, they're stabilized, but because of mods, right, and everything else, they die of the collective injury after the fact. Sadly, you saw that another school-age kid died in that shooting, right, so that would be late. 3 were dead on the scene. And this is horrible stuff, right? This is the stuff you do in the emergency and trauma. And then the 4th was the late. That 20% was late. Because they got in, resuscitated, but died of wounds, died of their sequela 24, 48 hours later. Which brings us to, this next piece. So the thing is, we talked a little bit, those of you at the caring conference, this is the piece. Why you have to be caring and have to be present. Because the patients that come to you in the emergency department are going to fall under alcohol abuse or victims of alcohol abuse. You're going to have patients that are risk takers and their lives are going to be changed, if not lost, and the families around them. And then violence, sad case of violence, penetrating traumas and blunt traumas of people that are going to be beaten, people that are going to be dragged, people are going to be stabbed and shot sometimes by their loved ones, sometimes random, which makes you scared because you know you could be random too. So you're constantly reminded of your own mortality, and then there's a correlation, right? Death rate in America versus industrial countries, and for gun violence, and then also intimate partner violence. All these things are sad, sad stories playing out in front of you. And all these things that are happening have, even a good case, where if there's a good case, it's just a clean case. Someone in their car driving home from work gets T-boned by a guy that missed the stop sign. No one's altered, nothing. T-boned, and the guy may die of his injuries. He was just going home. That's a clean case. There's not a lot of other precipitating factors, and that's tragic. But add all these precipitating factors onto this. Undocumented, damaged and hurt and scared, no place to go, no one to take care of them. All these things, beyond the trauma we're about to talk to, have stories of significance and loss and fear attached to them. So understand, when you want to go into this line of work, critical care, surgical, emergencies, trauma, they have stories. And if you don't have a way to take care of yourself, it's going to suck your soul right out of you. So I want you to understand, you do this, but make sure you're safe to do this kind of work for any prolonged period of time. Now, why SAMC, BAMC, the news can't get it right. I don't think, I'm part of the institution and I don't know what it's called anymore. But it's San Antonio Military, Medical Center. Sometimes we're still BAMC, Brooke Army Medical Center, but it's not Army, it's actually Air Force, Navy, and Army. Anyway, why do we provide trauma care to the populace in San Antonio? Being a military installation, why do that? Because it's the training, right? It's the training. Not only are we able to do a wonderful thing for the community, of course, all of our nurses and doctors constantly keep their skill set exactly where it needs to be. So what you're looking at, some of the terminology, so penetrating trauma for the civilian is handgun stab wounds. AR-15 is military-grade weaponry that is used a lot in Texas, in Houston, and in San Antonio. particularly Houston, there's a lot of gangs have military-grade weapons. And now you look how it works nicely over, because the military, very similar, you know, especially in Texas and Houston, with the fuel lines and everything else, there's massive explosions all the time, you know, not all the time, but quite often, with gas lines and everything else. So you have explosions. You have, between Houston and San Antonio and the large cities, because of the industries we have and the fracking and everything else, very similar injuries. So it's great for the military to provide level 1 trauma services to the community. And also they crosstalk, right? University, everyone crosstalk. Matter of fact, a lot of the surgeons work in a lot of areas. So it works for everyone. It's a great safety net. It's a great safety net. In Houston, there's 2 trauma centers for 4.4 million people. San Antonio has what, 1.6? Less than 2, right? So we got, in some ways, we got better coverage, maybe than even Houston does. Now, causes of death. This is the piece how we use terminology, which comes with the 3 modes. They talk the 3 modalities of death. So, pre-hospital, patients can die from hemorrhage, head injury, and pneumothorax. In the military, KIA is killed in action. Anyone that dies before they get to a level of care they can provide in the field is termed killed in action. But it's the same thing, just like here. Paramedics, right? Hemorrhage, head injury, and pneumothorax. And then you have in the hospital, like I talked about, where they're immediate, not the immediate, but they're early and late. Patients die in the hospital, hemorrhage, head injury, and sepsis. The only thing that's different, died of wounds in the military and the facilities, is head injury. We have higher rates of head injury deaths that occur in the military than in the civilian sector. Otherwise, everything's equal. And head injuries, it's really, those of you who will talk tomorrow about traumatic brain injury, as they get, us ready for phase 2 of monitoring and taking care of the head injury that Professor Stoltz is going to do, is the head injuries, because they have to be sedate. They can't have a lot of movement and motion. You have a dark room, it's supposed to be quiet, head elevated. Well, trying to get someone out of a platform that has to go from maybe, let's say, Iraq or Afghanistan and flown into either into Italy or into Germany for some care, and then you have to fly them one more time, transatlantic, over into the United States, to one of the facilities, receiving facilities, Walter Reed, San Antonio here, BAMC. I think those are the 2 platforms that receive most of the traumas. That's a lot of movement for a severe head injury. And when you're in the hospital, immediately, we can put these patients immediately, have our, we can do all of our interventions, and they set them up in the emergency department trauma room, and then take them to the OR, and we can put them into a specialized ICU room. So that's the only difference that you see. Everyone trains, so your nurses and doctors train for military combat, because they're special, they're different than you, because they're military, and they have to know how to do that, because you'll never see anything like that. This type of injury is only going to be seen in war. This is from Vietnam. See those legs are blown off? Thank God, as civilian nurses, you don't have to ever suffer this type of tragedy and monitor it, or do you? This is Boston. His name is Ballman, Mr. Ballman. I only remember his name because my cousin's Ballman. So his name's Ballman, he works for Costco. And he lost both of his legs. So the whole point is, we all need to train together, because the way things are going, we just had the mass shooting yesterday. You see in the civilian sector exactly what we see in the field. It's just, we have more tentage. But the trauma cases are the same. So those of you that want to do surgical ICUs, you want to do emergency departments, right now the world has changed in the last 20, 30 years. There is no line in the sand anymore. It's just, where do you work? So trauma is a huge issue. Mass traumas are obvious. So everyone has to be prepared at all levels to be able to provide this care. And you are licensed nurses. Some of you will choose not to be trauma nurses, but you may be thrust into the side of it. You may be put in the triage area and the collecting area outside the hospital if you're on a med-surg floor. You're thinking you're going to have cupcakes for your birthday that day, and you may be out in the parking lot triaging patients from some unknown in San Antonio International Airport. I mean, it could be a plane coming in belly first, and you can have, 200 patients flooding the system. So this is a good generalized course to talk about. I wish it was a happier story, but what we do in these dark moments do make it happy and makes it productive. This is, anyone see Black Hawk Down? John Holcomb, he's now a professor of surgery at the University of Alabama. He was my boss in Houston. He was one of the surgeons in Black Hawk Down. And this is his order set that he gave to the critical care nurse. Keep fresh whole blood going while the patient's hypotensive. Draw ABGs and fix the vent based on the results. Use any drug that's appropriate. Give pain meds if needed, and I'll be back in an hour. And critical care nurses did a fantastic job doing what they needed to do. And that's the piece. When you want this role, think about it. I'm asking, are you ready? Of course you're not. But the first time I presented this was at the American College of Surgeons. I presented the nursing component from Houston. So this is the question I'm asking. Anyone that has a license that wants to work in these areas, are you ready? Are you ready to get ready? It's not easy. It's a dedication, and really, it's a career, it's a dedication to life. Now, some of you may bounce in and out of this, but a good core of you, if I see you, if you come back for your class reunion in 40 years, I'll be dead. But you guys, technically I could not doubt it. Anyway, you guys come back, a good core of you are still going to be nurses. Now, how hard can it be, right? It's trauma, right? To stop the bleeding before it stops on its own. So paramedics have their job to do. Nurses in yellow, it's rapid assessment, coordination, and action. So you have to get the room live. You have to make sure everyone's coming in the room that needs to be there. You have to control the activities in the room and do your assessment and start the interventions with the surgical team, usually the surgical team. Anesthesia is going to put the patient, and get them on there. Intubate them, and they usually don't stay. They'll usually hand off to a respiratory therapist or to the nurse, put them on the vent, and anesthesia is out the door. And then your physicians, depending on the grouping of the physicians, either surgeons and or emergency physicians that are going to be in the room with you. So, right here, this is an easy case. Looks pretty cool, right? It's really a very minor case. I see the laser's not working on these things. Oh, yeah, it is. Okay. Just doesn't have any power to it. There. Okay. See that right there? That's the top of his eyeballs. All right? See that? All it was, he actually got like 60 staples. Right? He was in an old Mustang, Anyone know the old cool Mustangs? It had the chrome inside the window. And it wasn't properly seat belted, and he hit the chrome of his top windshield. I mean, he's conscious, but he's kind of messed up. But that's what we call a distracting injury, because it looks horrific. But in reality, he's not modeling for sure, okay? But we stapled him up, put him on observation, and he did really just fine. So that's the other part about trauma, because you guys are, right? This is what trauma patients look like. This is an easy case. This is an easy case with a nice, good outcome. But you still have to assess them all the same, right? So now, this is a little different. This case is much more critical. See, is that his mouth open? No, that's his chin. His lips are above the finger. Reorient. That's not his mouth. That's his chin. He is unconscious. He is a level 1 full resuscitation.
The chin.
That steering wheel split him wide open. What? Yeah, that's his chin. Fractured jaw, everything else.
Right here.
Now, immediately you think, oh my God, airway, breathing, circulation, right? What do I got to do for this patient other than gawk at him? So there is a thing about trauma, you have to learn how to desensitize a little bit to the distraction of the injuries, because it's horrific. Some of the things you're going to see. So, what's a designated trauma center? So University Hospital, BAMC, Ben Taub, Herman in Houston. In Austin, it's just like in Colorado, the name of the ski hill. Huh? Well, it's a ski destination in Colorado too, it's Breckenridge. So, and actually those nurses would come down as contractors. I didn't have to orient them or anything, they were awesome. From Austin, I could just release them into the trauma room and not worry about it at all. So anyway, you've got those trauma centers, and you have Parkland and Dallas, right? You all know that from John F. Kennedy, if you guys are history buffs and everything else. Parkland is, a matter of fact, Dr. Eastridge, who's at university, cut his teeth as a trauma surgeon in Parkland, did the military, and now he's the chief of surgery here at university. So these are all trauma centers. So here's the deal. Level 1, those of you that are used to NICUs, a level 1 is a low level, right, for NICU. So it's just a little different, so don't get confused at testing time. Level 1 is the big dog in trauma, whereas the NICU is just the opposite. The higher the number is different. So level 1 is big dog. Level 2, I think Methodist is actually trying to get level 2 status as we speak. And then level 3 is just, you know, they have some surgical capabilities. So level 1 has to have everyone that's on that transplant, limb reattachment fellows, along with cardiothoracic, neurosurgery, general surgery, massive orthopedic surgery. Everyone has to be on the books to be a level 1. Everyone has to be 15 minutes or less within response of a level 1 trauma center for them to be level 1 designation. So you can imagine the cost and the expertise required in a level 1 trauma center. So you can almost guarantee it's always going to be a teaching hospital of some sort. It's the only way to ever run a level 1. Level 2, they can specialize. So I think they're going to specialize in neuro and some other, and maybe cardiothoracic and Methodist. They're going to pick a window. Now, remember, level 1s are part of a system. So there's a way to get people there. So this is what we have. We have a thing called MedCom. It's Medical Command Communication here in San Antonio. It's a centralized group that all the ambulances talk to, and you have status boards. So I can see the trauma cases the university had when I was at BAMC, and university can see what's going on at BAMC, back and forth. And MedCom has eyes on all the hospitals. And they'll be, okay, such and such, we have 17 patients here in a motor vehicle accident, this is what we have. Do you have 4 that need to go to a trauma center? And then MedCom will look at the numbers, and they will designate where everyone's going to go. So it's actually a pretty good network in San Antonio. It is. It works very well. And so the ambulance based off of that. Now, family member or the patient can't override the request in most cases. You can't override where you want to go, but you don't probably want to do that unless you're a healthcare provider yourself and you're specific. And they will scatter you to make sure resources and everything else are available. So that's what happens. And these are the types of injuries that are going to require immediate transport to a level 1. Pulse trauma, mind you, these are vital signs based off of a traumatic event, not just slow heart rate. So someone that has a pulse of lower than 60, mind you, they're traumatized. That should be very concerning, right? And then, of course, higher than 100 means that probably blood loss or something else occurring, respiratory rate, and everything else based off of that. It's really going to be about volume and blood. Continue. So these are the other things that you're looking at. Anatomic, got flailed chest. We all know what that is. Pelvic fractures, open book fractures, where sometimes you'll see the pelvis fracture goes and it's completely flat and the feet are sticking out. And there's remedies to that. The problem with that is a lot of blood vessels go through there, externally and part of the pelvis. So a lot of hemorrhaging can happen. So the pelvic patients have to get in immediately. And of course, anything with paralysis, amputations, for the hope, a lot of times with amputations you can do a limb reattachment sometimes, or at least hands and fingers to some degree. And then burns, especially to the face or airway, because we talked about that, how bad you can swell after a burn. You can not sometimes identify someone within an hour or two. You have to get that airway support. And then, of course, mechanism of injury, MOI. So here we go. Report comes in. Kind of when you were reading earlier, and then you're doing vital signs. That's what a trauma room sounds like, because the ambulance will call in. As they're arriving, they'll give you the scenario overhead, and you'll be standing there, and everyone's listening. But everyone has a role. Everyone knows where they belong in that trauma room. It's not by chance. You have a placement and you have roles and responsibility. So when you're hearing certain things, you're already thinking, I'm getting blood, I'm getting ready to intubate, I'm getting a chest tube. All those things are coming in. So you have to be able to prepare yourself mentally. Bless you. I have no qualifications to bless anybody, for the record. So, anyway, this is the trauma room. We're actually actively hearing, that's me, my hand telling, I'm talking, telling everyone else to be quiet, right? That doesn't make sense, but that's my hand. And I'm telling, hey, so they're listening. That guy at the head of the bed there is the third-year resident who runs the room. And then you have the monsignors, the senior chiefs, are off to the side. They're not going to intervene at all. Let the third year do his piece or her piece. And then you have the nurses there to the right side of the bed. As you can see, their back, they're doing blood. Joe Golash is there. He's getting ready to do monitor and IV. And then anesthesia, hands on hips, actually CRNA. And he's standing there with hands on hip, and he's getting ready to go do his role. Everyone is thinking about what they're going to do on the team when this patient arrives in just seconds. But the report was coming in. So when we get the patient coming in, you have everything coming in. What are our physiological signs? What is the anatomic location of the known injury? And then a mechanism of injury. And then what else? The resources, environment, and transport. Because sometimes patients, it's cold. Even in Texas, we already had a night in the low 40s already. And if the patient's in rain, and they're in a vehicle, and they've been stuck on the side of a hill, and they're damaged, and they've been trapped in the car, and it took an hour and a half for, the jaws of life for them to extract the patient and transport them, that patient's going to have environmental issues too, because hypothermia is going to be a problem, and we'll talk about that. That's huge in resuscitation. So you got to take all that into account. So again, this is really important. That was my whole point. The trauma team can only look or listen, but you can't do both. So I wanted the room quiet. There's a little bit, actually, I gotta say, Ben Taub really does a good job of quiet time preparation. BAMC, it was one thing, I was there around the place for over 3 years, and I didn't even make a dent in the culture. I wanted the room to be quiet. I wanted it to be like Ben Taub, but I never won. Never won. They just talk. They just talk. Anyway, you all know Miller, right? So anyway, MIST, mechanism of injury. It's a nice little, mnemonic to hang on to, and then injuries found and suspected, signs, and then treatment given. Now, in Houston, the nurses were crazy tough. They were scary tough. And they would shut anyone down. They vanguarded that handoff, huge. If the paramedic did not have absolute silence in that room when they were handing off their care, previous care, and conditions of the patient, the nurse would go berserk. No third-year resident wanted to deal with a senior trauma nurse, I'll tell you that right now. So they would. Everyone was pretty parochial about it. Paramedics would come in before the surgeon started, hollering out anything. Everyone listened to the handoff until he said, I'm finished. And then questions or answers, and then they departed, and then the team jumps in. And that's really, really important to get your mindset set up as a nurse. Because remember, you're thinking the entire time. Trauma is easy in the big picture, but there's so much that has to happen almost immediately at the same time. It is a coordinated team. Really, a good trauma looks like a beehive. Everyone's just moving around over the top of each other, and it's actually, sometimes it's a symphony when it works right. Because you're saving lives, you understand that. You are literally, sometimes these patients are minutes from death. And they're turning it around sometimes. And really, some of these surgeons, they're nasty human beings sometimes like to have to talk to in the hallway. But some of them have talent, amazing talent, and I'm willing to suffer any butthole if they have talent like some of these guys have, That's amazing. Beating hearts, pulling holes together on them while the heart's hemorrhaging. It's like, okay, you can be that guy, I'm okay with it. You just literally saved that guy's life. So anyway, what are we looking at? Restore tissue microcirculation, correct metabolic abnormalities, restore hemodynamics. Basically, we're trying to stop shock from occurring. And then again, in trauma, assume the worst case scenario. This patient's dying until otherwise proven. So there we're going to move forward. So the patient's here. Now where do we start? So we start our initial evaluation. The physician's going to do an evaluation and assessment. Does not negate your responsibility to the assessment as well. You got to remember, some of these docs are in training. Most of the nurses in the room, almost all the nurses in the room, were not in training. They could auscultate. Some of them had 20, 30 years on these young docs. They had better ears, better assessment skills. Both do the assessment and discuss findings. So primary survey. So you quickly do airway, breathing, and circulation. Now, it's simply, anyone watch the show called ER? It's kind of old, right? With, what was his name? Clooney? Yeah. Clooney and those guys. So they would do that. Actually did a pretty good job. They were basically using Cook County as their backdrop in Chicago, which is a trauma center unto itself too, especially these days. But if a patient's going, I can't believe she shot me, oh my God, she freaking shot me! What do we know about that patient's airway, breathing, and circulation at that point? And what about the disability? They actually are aware of what happened. They're basically telling you what happened. She got shot. Now, if she said, you're not my last nerve, you probably didn't listen to that. But the fact of the matter is, we do know momentarily, because mind you, he's been shot, momentarily, we have airway, breathing, and circulation and disability minimal at this point. That's a captured point in time. 2 minutes later, it could be a very different story. But that's what we know upon arrival. Or there's deficits, one of the two. So it doesn't take much to get the information you need initially from the patient. So that was quick, right? So now, interventions. What do we do? ABC junctures. What's your role as a nurse to ensure life-saving procedures can be done quickly and safely? Now, here's another nice mnemonic. I love mnemonics because it keeps you honest. When things are, when everything's hitting the fan, whatever you want it to hit the fan, whatever you want to call it, when it's hitting the fan, you know, if you do not have a rhythm, you will lose the ability to dance. You have to have stuff that you can do almost unconscious because it's stressful, and you work on brainstem. You literally are doing this stuff on brainstem. There's times I've walked out of rooms after being in there an hour and thinking, what did I just do? You know, I have no idea. You really sometimes, you're doing everything right, but you're just so autonomic, you know, move. And everyone's hand over hand in a well-trained team. So trauma teams at university is a little different than BAMC, real quickly. They handpick nurses from the emergency department to become trauma nurses. The pit, anyone familiar with the pit bosses, right? The pit bosses handpick the nurses, and they specifically train them in the trauma resuscitation. Not necessarily a fan of that process, but that's their process. BAMC, you worked your way up to it. Everyone had an opportunity to become a trauma nurse at BAMC. That was the last area you went in, running the place, you know, being the charge nurse was the last thing you did, but trauma was next to the last thing. You worked your way to trauma. You worked through cardiac, you worked through all the different areas, and you finally made it. Now, did you normally go into trauma after you did a couple of months in there? Sometimes you didn't want to be in there, sometimes we didn't want you in there, most of the time it was mutual. Not every nurse stays in trauma, but everyone gets an opportunity. University, so if you get hired in the ED, you have probably a 20% chance of being a trauma nurse. Do you know that? They handpick their teams, and that's just the way they do care. The surgery group is very particular, the nurses they work with in the department. The emergency room docs don't even go in the room, for the most part. It's very unique. So it's a specialized team, PAs, there may be a practitioner or two on it now, and then your surgeons, respiratory therapists are handpicked, and the nurses are handpicked at university. At Ben Taub, everyone also had a chance to rotate through. So here's your little bit that you have to do quickly: airway obstruction, tension pneumothorax. This is what all trauma surgeons occasionally miss: cervical fractures. So these are the things that you don't see immediately. These are not the obvious, like the guy's forehead hanging on his face. That's obvious. But these are the things that can be happening that you don't necessarily see, but you have to assess for and suspect. You know what tamponade is? The blood around there. Remember, fascia does not expand, so it's tight skin. So anything that gets in the way of it can start to compress underneath it. And then flail chest. So everything else I have talked to you about. So airway, and they say little c, in trauma cases, it's really important to make sure you don't worry about C-spine precautions and shootings when you extract the patient. This is just front matter. That was like Black Hawk Down. A lot of our medics were lost because they were worried about C-spine on patients that were shot. If you're shot, you have penetrating trauma, either it's broken or it's not. So if they would have not stayed upright, they would have been able to get that patient extracted safely and not been injured themselves. So airway though, you always got to think, no matter what you do, even if you do a jaw thrust on a patient versus a neck tilt, you got to worry about cervical spine issues though, okay, especially in blunt trauma. Coup contra coup, we talked about it, right? So head forward, head back, hyperextension and compression can occur. The patient may seem fine until they're not. Side story, I took care of when I was in nursing school at the University of Wisconsin, go Badgers. Anyway, he was a quadriplegic, and he had been drinking, and they were goofing around in a pickup truck, and he was ejected through his windshield of his pickup. And he was fine. He said, oh man, I was laying there, and I even said, don't move me, and then they moved him, and he remembered, he felt everything just go. So by moving him, they severed his spinal cord, and he remembered everything going away. Now mind you, he's a pretty cool guy. I would go up there and I got authorization. He'd like Moosehead beer, and I would put a beer in his mouth and he'd chug it, and stuff. We had a good time. That was fun. But he remembered because of airway, they were so worried about his airway, they forgot about his C-spine and they severed his spinal cord. And he was conscious, so he remembered it. It was kind of a horrific story. Obviously, 35 years later, I still remember to this day. So these are things: patency, voice, stridor, blood, neurostats. These are all things you're going to start picking up when you're doing airway. And then treatment options. What are we going to do as a nurse? You got to be looking at supplemental O2 at a minimum. You're going to be working on suction. You got to do chin lift again because we're looking out for that C-spine. Most of these patients in their package. You got to remember also in gang activity on Friday and Saturday nights, not all patients come in via ambulance. There was an agreement if people brought their buddies in. We didn't make eye contact with the drivers or even take time to look at a license plate or identify the car. We would go to the back, or sometimes they'd push their buddy out and drive away. Either way, we would receive patients in Houston pushed out of the car or pull them out of a car also. So those patients obviously don't have C-spine precautions. But in some ways, they're there so rapidly, they grab them right from, after the penetrating trauma occurs. In some ways, they do them a huge favor versus laying there and stabilizing. But most of the cases, you're going to receive a patient that's going to be in C-spine precautions on the backboard, take down, full point of precaution. So you have to go to great lengths sometimes to try to get to a patient's chin lift, even because of the trauma, the way they're wrapped up. Then we're going to be talking oral airways and nasopharyngeal airways. What do we know about an oral airway? Does a conscious patient get an oral airway? The answer is no. Do we use then probably an alternative? Nasal, right? Because it's better tolerated. And then, of course, the surgical airway. And that can occur very quickly. The decision can happen quickly, where they have to do a surgical cut down. And the nurse is all part of that. And now remember, 2 to 10% of unconscious patients with injuries above the clavicle will have, concurrent, C-spine injuries. So anytime you see trauma around this area, the upper chest, you already have a 1 in 10 or better chance that that patient is going to have a C-spine injury as well. It doesn't have to be a fracture. It can be a ligament too. And also Brown-Séquard syndrome, you guys remember spinal, you don't have to fracture. You can just hyperextend and compress the spine without a fracture being present and cause further harm. So you have to always be aware, and all you're doing is, hey, we just started. So we got to look at now the neck 6 times, primary survey. We got to look 6 times. Neck carries airway and circulation to the brain. So there's a hard collar there. That's where your team grabs the head, stabilizes the head, open the collar. So you can look at the neck and no one moves that patient as you're looking at the neck, and that's what you're going to look for, right here. Can you guys see the graphic okay? So you want to see if the deviation of the trachea, which is a late sign for tension pneumothorax. You're going to be looking for an expanding hematoma in the neck, which is, your arteries are running through the neck, and then surgical emphysema, which is also subcutaneous air, and the airway fracture or rupture, that everything fills up like a balloon. The skin fills up. It almost feels like you guys like popping those plastic bubbles. It's exactly what it feels like there. You can feel it and see it. Do not pop the bubble. Now, then also laryngeal fracture. Someone gets hit, steering wheel to the throat, baseball bats to the throat, steering wheel to handlebars. Tons of different things can cause a fracture to that. And we see distended neck veins. What are you thinking? Or arteries? Not congestive heart failure because this is a trauma patient. Now, it could be a congestive heart failure patient that had issues and had an accident, but we're going to assume here that we have probably tension pneumothorax or cardiac tamponade. So this guy, he was a taxi cab driver, there used to be taxi cab drivers instead of Uber. He was on, he had about 20, 30 miles an hour, and he wasn't seat belted, and he took the steering wheel to his mouth. So the big problem on this one, he didn't actually end up getting intubated. He just had to clear his airway, get some coverings for his teeth because of the air motion across fractured teeth, needed dental surgery. But he was discharged late that night, even though he looks like this, cleaned up, and his neck was cleared, and it was really turned out to just be oral surgery. But of course, he got the airway, breathing, circulation, he got the whole trauma treatment, and it was just a better story. But the big piece on this is people think, oh, we have to intubate, and focus so much on intubating, they're forgetting to oxygenate the patient while they're getting ready to intubate. Patient needs oxygen. Intubation is just a conduit, but we need to get oxygen on our patient. Nurses have to pay attention to that, all right? Especially in teaching hospitals, residents are worried about the procedure. Let them do their thing. They need procedures. We as the nurses, we got to make sure our patients are getting oxygen. You worry about that, okay? Just make sure it's happening. So when do you need to intubate? When you do this, there's certain things you got to grab. We have kits. Those of you who are lucky enough to see the trauma, you've been in the trauma room? So you have kits, they open up kits. Now the kits, this is an example. Each chief of surgery has their own idea what a kit should look like. Anesthesia is certainly going to lay in on this one. This will be the chief of anesthesia, fix what this kit looks like. This is what the kit looked like in particular at Bentall. There may be variations from trauma center to trauma center based on the practicing group that's there. You know what RSI is? It's not ESI, it's RSI, which is rapid sequence intubation. So along with that, nurses often are going to be pushing the paralyzing drugs and the Versed and the sucks and everything else, pushing this at the very same time that they're doing cut down and or doing the intubation. So nurses are involved, you hand off the equipment, they get the equipment, make sure everything's functional. They're doing their piece, you're stabilizing, and you're also getting the IVs ready, and someone else is pushing these drugs, so you do not want the patient conscious with memory when you're intubating. So this is the same guy, we were looking at his chin. This is after he's been stabilized. Remember, we were looking at his teeth through his chin. This is what he looks like. So you can see he's intubated, he's got a nasogastric tube in. You know, we opened the collar because we're looking further at investigating the rest of the secondary survey. And his eyes are closed, so he was very much alive. He had to go to neuro ICU for a good while. I don't know his final outcome. But he made it through surgery. He made it from us to surgery to the ICU. And you saw he's pretty messed up, a lot of trauma there. So his airway is good. And if you can't get the airway, this is what you have to do. The crike. Everyone says crike. You've heard that term, crike? Well, Dr. Maddox was always, in the middle of a trauma, he was a stickler for semantics. Crike is not a word, it's cricopyotomy, right? And you're like, oh, whatever. Either way, we're going to make a hole in his neck, right? But anyway, yeah, certain things. How many surgeons are legends unto themselves? They really are. And Dr. Maddox, he's internationally known and talented but quirky. He's fired nurses halfway through trauma resuscitation. Of course, he doesn't have the power to fire anyone, but they had to leave the room and take a time out. You know, just anyway, you're going to see that some of these guys, the better they are, the crazier they are. And the rooms all have a certain flavor. It's a lot of fun, and it's kind of weird all at the same time. So anyway, you prep the site. Nurse is going to help with that. And they're going to get ready to cut in. You're going to be working right in there, handing off equipment, prepping the site, holding the sites based on instructions, and the team's going to have a certain way of doing it. Either way, you're going to put a tube. Now, in the ICUs, it's a clean procedure. It's actually an actual tracheotomy going in that's occurring. In the emergency room, it's going to be an ET tube cut off, adapter adjusted. And we're going to secure that airway, because remember, this patient's failing right in front of us. So we're going to do an emergency cut down. So this is clean. You'll never see it this clean in the trauma room. This is what you'll see in the ICUs and everything else. Now, if you want to reach up and fill that gap in your own cartilage, do you feel that window? Feel that little cartilage window? That's where we're going. That's why we can't do that on peds. Remember, their airways are different shape, so we cannot do crike on a pediatric patient like this. So on adults only. Feel the window? I'll find it. So anyway. So now, that's airway. B is for breathing. So breathing, look, listen, and feel. Skin color, right? Skin is the largest organ that's going to tell what's going on also. Cyanosis, see the level of respiratory effort. And also remember the paradoxical breathing of that kid, right? The chest injury, and the tracheal breath sounds, listening both sides, especially when you're intubating. You want to make sure you have breath sounds on both sides. So, treatment options, ET tube, needle decompression, chest tubes, thoracotomy, right? Versus thoracostomy and analgesia. Make sure, again, we get pain medication on board on a conscious patient. Getting your chest wall cut open, even if you need it, is not a pleasant experience at all, especially without pain medication. As a nurse, you need to advocate for that moment. Get little lidocaine on board. So you have poor breath sounds, you get tracheal shift, obviously. You have either pneumotension, pneumothorax occurring. This patient is going to die without interventions. So you're going to be doing chest tubes, sometimes 2-3 chest tubes on these patients, rapid sequence, hand over hand. So how do you prepare for this? You know, needle decompression. If you have to do a needle decompression where they're getting everything ready, I've done needle decompressions maybe 2 or 3 times in over 30 years in trauma. And most of the time we can put a chest tube in almost as fast as you can do needle decompression. Most of the time you do needle decompression is going to occur usually on the ambulance. But we did have a guy that was brought in long distance on an ambulance, transport time. It was really bad shape, so we darted him while we were getting the chest tube going in. And it does sound, you can hear the air literally coming off. And you can almost immediately start to watch the hemodynamics of the patient change. So, with that, you do that. And that's going to usually be the second midclavicular line on the chest wall right here, second midclavicular line. So now the patient's going to get a chest tube of some sort anyway after you do that. So now it's your chest tube. So let's get our chest tube going. Don't worry about that. That's just a little extra something you don't need to worry about. Scalpel. We're going to need a scalpel. We need a large curved clamp. We need a large straight clamp, because remember on the end of the chest tube, I talked about that in the pulmonary, we have to clamp it off or the blood's going to go everywhere. And guess what? You're the one that's on the ground trying to put the chest tube onto the apparatus, and you're the one that's going to get sprayed. That clamp is in your best interest. The guy behind it doesn't care because the blood's going away from them. So, scissors, silk, you got to sew that thing in place, analgesia again. So get ready, let's do it.
What age are we going to be required to know?
No. Equipment? No. It's just giving you context, though. This is the nurse's domain. You will learn that stuff ad nauseum when you get hired. Again, so you can see this is, again, the bullet hole is the top, and then the blow up on the sidewall there, and then there's a chest tube in place. So C is for circulation. Now we're going to do, right? We got to make sure our patient has circulation. We're going to be doing all the things you need, pulses, quality of pulses, and then you're going to do 2 large bore IVs just as safety lines, because you want large bore IVs, because if you have to give blood, which you probably will, you got to have a way to deliver it without lysing the red blood cells and you're rapidly infusing. Now, shocking news, right? So this is the big deal. When some shock occurs, this is when those patients die late in the ICUs. A lot of it has to do with how well we do in the trauma room, because if we keep the patient in a shock state, and we let their blood go too low, we've started that collective death roll of MODs. Multiple organs are going to start to choke off. So we got to keep patients as hydrated and pressure as good as possible to a certain degree, and blood on board to avoid the shock. Because shock often, especially in trauma, becomes irreversible. So again, trauma triad of death, not the actions of people dying, but this is the triad of death once you're resuscitating the patient. Things that can kill off a patient before the wounds is going to be hypothermia, it's going to be acidosis, and coagulopathies, where you start to get DIC, right, where the blood starts to cling onto itself because you've caused it. Because of the temperature change, because of the amount of plasma available, the clotting factors are going to malfunction. So we got to get blood on that patient, and we got to keep oxygen going. So evaluate the response. We're going to be looking at, this is just straight on down, urinary output. The quicker you get a Foley in the patient, the better, because we're going to get core temperatures on the patient, and we're also going to be able to start monitoring the circulation, and urine output is a huge indicator of how well we're resuscitating the patient. So irreversible shock, vasomotor failure, hepatic failure, and cardiac failure. So what you do in the first couple of minutes and then continued care you do with the patient really keeps you in that, the early stages. It allows that patient to successfully navigate the late stages and avoid dying in the ICU days or weeks later. Now, can you always avoid that? No. That's why you have to know your job and you have to know it well, because patients will die. And again, if you did everything right, you've been trained, and you did everything accordingly, it's always regrettable, but there's no guilt. Because when you enter into the resuscitation, you are making a contract with the patients and their loved ones that you are going to do everything you can do. You are not a spectator. You are a participant, and you better know what you're doing, or please do not enter that room. I beg. That's one time. I'm not a very serious-minded person, but one of the things, safety, and patient care, and contract of presence with the patient are things that I will die on my sword over. So, things you have to understand for terms: fresh frozen plasma, and then massive transfusion protocols. Now we are moving towards whole blood. Dr. Schaefer, she finished the MP here. She was, actually there'll be a picture of her at the end. She actually did, part of her work for a DMP project was getting whole blood on the ambulances. Whole blood is by far the best replacement for lost blood. But right now we have a ratio of how many packed red blood cells to plasma we can give. And we also did factor 7. That's just something we can use. It was used in combat. We used factor 7 for patients that were way out of surgery. It allowed, like, if you let their blood pressure drop, we can actually cause clots, soft clots, kind of keep them from bleeding to death. But factor 7's been on and off the market a couple times because it works. But there's a weird phenomenon where clotting occurs. Clotting occurs spontaneously sometimes weeks after. So that's the part they're working on right now. It's a Swiss research group. They've used it on and off. Some it might be on the market again, it might not. So trauma care in particular, you see in Iraq, right? We were doing when normally it was when I was at Bentall, we were still 1 to 4. So for every 4 units of packed red blood cells, we gave plasma. That's your clotting factors, right? And then getting close to whole blood, because you had big trauma cases, all young guys and girls there, we would use a 1-to-1 ratio. So immediately, based on the results, everyone in the United States went 1-to-1 ratio. It was a huge resource, huge great resource to go 1-to-1, 1-to-1, 1-to-1. And we backed off of it in the military, said, okay, that's great results, but how far back can we go and still get good results? The civilian sector moved to it because, first of all, they're a little more resource rich. Blood transfusions and everything else, and blood donations are much easier to get, and also maintaining blood was better. So 1-to-1 is the move, but now we're actually going to heck with that. We're moving to whole blood. There'll be better ways of testing. The reason why we weren't doing whole blood because of Hep C, HIV, and everything else that was occurring, but now they're able to screen really quickly and successfully, where whole blood now is becoming very much a reality. So we're not going to go into this, I just kind of covered it. So the biggest issue, though, wasn't so much 1-to-1. I want to point that out. It was the decision from the time you know you need to get blood on your patient to the time you actually get blood on your patient. It was the window of I need to get blood for this patient to the window to getting blood on the patient was the most significant data point, which makes sense. I can tell you at BAMC, old BAMC, before it's been redesigned, I had to always, at the beginning of shift, I always had to ask who our fastest medic was, because they had to go from the first floor to the 4th floor on the opposite end of the med center to get the blood. However it was designed, the blood lab was on the other side of the hospital on the 4th floor. So the time we would think we needed blood, we sent the guy like Mercury, take off running to get blood and bring back a cooler full of blood so we could start the process. So because of this data, the obvious as it can be, blood now is usually in the rooms, pre-screened and in the room, so we have it when we need it. So that's the most life-saving, obvious thing, and it took forever for us to get there. So, hypothermia, be afraid. This is a nursing intervention exclusively, because the surgeons in particular are going to keep that patient naked and looking head to toe and thinking about whether they're going to stick a chest tube, if they're going to have to do, some sort of work on the abdomen, they're going to tap the abdomen, they're going to have to look at the legs if there's like fractures. You have to make sure your patient stays warm. Now, the trauma rooms usually are kept at 85 degrees. Burn centers are usually kept at 90, 95. You gotta at least cover those patients with warm blankets, exposed, and first of all, you gotta get a good look see on your patient, front and back. But after that, let's keep that patient covered except where procedures are occurring. And trust me, if you don't do it, no one else will. Respiratory is not gonna do it, right? The surgery team's not gonna do it, anesthesia is not gonna do it. You are going to keep that patient warm. And you may look like a nerd. I'm only saying that from personal experience because I'd always walk in with like 8 warm blankets and they're like, oh, he's back, you know. But I kept my patients warm. And it wasn't my cases, you know, I was running the place. But I was like, I just knew I couldn't trust anyone to keep my patients warm. So that was my thing, it's my hang up. But it saves lives, believe it or not. As simple as it looks, it saves life. So this is what it looks like. This is a case. This guy, I remember in particular, was on a motorcycle and went off the ramp and landed, and his pelvis drove through the entire bike, broke the bike in half. His pelvis was shattered. He took 40 units of blood. Died of a head injury. Died of a head injury because he didn't have a helmet on. And of course, when he hit the ground, his head hit the handlebar. So it was a head injury that he succumbed to. But for the record, he did not bleed to death. I know you got to hang on to what you can hang on to. Those are the things you have to walk away with. You have to know you did your job right. So when pulses are lost now, we have to make quick decisions, especially in penetrating trauma. So everyone's going to go crazy. You got to decide now. They're going to open up the chest wall. Again, that's a surgical piece. It's going to be cardiothoracic in particular. They're going to open up the chest wall, but you're going to be right there with instrumentation, opening the kits, providing, you know, the level 1. You're going to be running blood transfusions going on this patient. Things are crazy, especially when the pulses are lost. So this is what it looks like. Again, you do not need to know anything, just understand. This is the kind of stuff when you're a nurse in that room, you're going to have to learn. You're going to have to open up that kit, and all these things are going to be things you have to hand off. And there's a rhythm to it. They're going to say, I need, because they got to remember, they keep their eyes on it. They're going to do this, and you're going to slap something in their hand. You got to know what it is, and you got to know each other. And I'll tell you, even after like 2 days off, if I ever got 2 days off back to back, and I was in the case, and my first day back, they're pulling something out of the kit, darn if your rhythm isn't off just a little bit. It'd be like, sometimes they have to grab twice like this. Normally one hand, sometimes they go twice and you're like, oh, I'm off, you know. So it's a skill set. It's almost, you know, an athletic event. So, thoracotomy tray, here we go. This is what the instruments look like. Again, this is just for context. And those right there are spreaders and internal paddles for the heart. So let's go. Here we go. This is what it looks like. We open, then we spread, and we go through the area to get to the heart and the lung. And right here, we're running in red roosters, actually red catheters, pushing blood directly into the heart where the hole is until they close it. This is a double thoracotomy, or nicknamed a clamshell. Open up both sides. This case was tragic, and I don't want to go into the story right now. I'm not in a place where I can do it, but it was a very sad case. But we did everything we could for him. He was shot by students from behind with a shotgun, and they blew him apart. Amazing man, died a tragic death. A couple students that were suspended and were shot. Anyway, now let's do D is for disability. So you can see right there on the CT with contrast, you can see there's a huge hematoma brewing within that area. Now see, it's close to the skull, so that can be evacuated. That can be evacuated. Sometimes we'll do it right in the emergency room. They'll drill into a borehole and get that blood pulled off. But you got to be very careful because if you decompress too quickly, you can change the intracranial pressure and you can have a whole lot of stuff going on. It's not a simple procedure. Sometimes less is more. And it's the neurosurgery team specifically that's going to work this. You're going to support this patient best you can with meds, positioning, and everything else. But these cases are very complicated and require a lot of different things. So this is from the outside in. I'm going to go through this tomorrow. We're going to skip through this because this is what our lecture is going to be tomorrow. Because this used to be the last lecture. So now it's not. So we do neuro last. So I'm going to walk you through all this tomorrow. This is the anatomy of a head injury. We're going to go through all this. We're going to do all this. We'll do this. We'll do this. We're going to do this. got somebody that was shot in the face and the swelling that occurred and everything else, right? Got to watch for subtle changes, you know. And I'm going to go through all this with you guys tomorrow, and then the stabilization is going to occur with. It is Stoltz, right? Those are Stoltz, Dr. Stoltz, or is it Bryce? All right, so watch for the changes. I'm going to skip all this because this was like 3-4 weeks apart at one time. This data. This is now back to back. So this right here, I should show you on this one is, see that thing that's glaring? What do you think that is? You guys know shotguns, right? Right? So that guy got shot with a shotgun, and one went into the orbit of his eye. Neuro assessment, we know all this. So again, ABCDs, disability, traumatic brain injury, we go through tomorrow ad nauseum. So we'll do all this. So start your secondary assessment, and then you do it again, and then you do it again, and then you, guess what? Do it again. So this one right here shows you that if we take off part of the cranium, they will actually sometimes, instead of sending it to cryo and freezing it, they'll put it sometimes in your abdominal cavity just to keep the bone alive and warm. And, you know, huh? Yeah, that's half the cranium right there. So again, remember, death begins at X-ray. As you can see right here, look at the patient's intubated, this patient's on a monitor. How many doctors and nurses around him? I took the picture from the leaded glass, okay? So you've got to really be very careful. Watch these patients. We need the evidence, we need the data, but this is a very critical time for a patient to be unattended, especially because we're still trying to figure out what's going on with them. So all this happens literally. This happens, this is a walkthrough, but this all happens in minutes to half an hour, and then the part that takes long is just the repetition of constantly doing and doing and doing. But the stabilization can take place in a little 10, 15 minutes. All those things, 10, 15 minutes. That's why it takes so many people in the room, though. So those are some of your nursing diagnoses. Look at those. I don't test on that, but it's really good for clinical. So anyway. So these are some resources that you're interested into it. Come talk, see me if you're really interested in doing emergency trauma nursing. You guys just come down. I have an open door. I'll talk to you about it, but no need. So we'll do this next semester, team communications. We will do this. That'll be one of your interprofessional education days of dental students. We'll do that together. And then simulation. Trauma simulation is huge. Actually, we have an article. If you really want to read an old, boring article, I'll flip it to you if you want to see it. It's about actually using teams, established surgical teams going through simulation have much better outcomes than going through simulation. So definition of a trauma nurse.
Yeah, exactly. What they say?
Read it.
Read it. He's in the interview. Read it, guys.
So again, this is trauma room 1 at Bental. And then I just do again, kind of close it out. There's a military, trauma bay, which is actually much cooler now than that. But anyway, that's what a trauma room looks like. That patient got whisked up into the trauma elevator, is up in the OR, but that's what the room looks like. And we turn it over, that room gets turned over in 10 to 15 minutes, max. So again, everybody grab something. We gotta clean that up because the next patient's on the way. Room ready or not. Oh, so there's Randy Shaper right there in the middle. So she's retired trauma nurse now too.